5 health checkups to skip after 60. They may do more harm than good. If you're over 60, you probably think regular health checkups and screenings are your best defense against serious illness. But here's what the medical establishment doesn't want you to know. Each year, millions of unnecessary screening tests are performed on older adults, resulting in thousands of serious complications that could have been completely avoided. The truth buried in the research is startling. At least half of older adults in the United States had received at least one unnecessary cancer screening test in the previous few years. But I'm going to share something with you today that might shock you even more. The second most surprising fact is that these tests don't just waste your time and money. They're actually creating false epidemics of disease among healthy seniors. And the number one revelation that could transform your approach to healthcare after 60. Some of the screenings your doctor routinely orders could literally be more dangerous than the diseases they're meant to detect. Before we dive deep into these 5 specific checkups you should question, I want to hear from you. Drop a comment and let me know your age and where you're watching from. Have you ever had a screening test that led to more procedures or treatments that didn't seem to help? Your experiences help others navigate these choices. Let's start with number 5 on our countdown. The routine urine test that's creating antibiotic-resistant superbugs in nursing homes across America. Here's something that would surprise most families caring for an elderly loved one. Up to 50% of nursing home residents have bacteria in their urine, but no symptoms whatsoever. This condition is called asymptomatic bacteriuria. It sounds scary, but it's completely normal for older adults. The bacteria aren't causing any harm. They're just living peacefully in the bladder. So why does this matter? Because when healthcare workers routinely test urine in older adults without symptoms, they're almost guaranteed to find bacteria. And when they find bacteria, they reflexively prescribe antibiotics. Research from UK hospitals found that most cases were asymptomatic and therefore received an appropriate antibiotic therapy. This creates a cascade of problems. Here's the mechanism in plain English. When you take antibiotics for bacteria that aren't causing symptoms, you don't cure anything. Instead, you kill off the good bacteria in your body and create conditions for resistant bacteria to flourish. Studies show that treating asymptomatic bacteriuria increases your risk of getting a real UTI later on, and that these UTIs are more likely to involve antibiotic-resistant bacteria. Let me tell you about Margaret, 78, a retired librarian who loved her weekly bridge games. During a routine hospital admission for a minor fall, someone ordered a urine test as part of standard protocol. The test showed bacteria. Within hours, Margaret was started on antibiotics for a urinary tract infection. She had no burning, no urgency, no fever, but the test was positive, so treatment began. 2 weeks later, Margaret developed severe diarrhea from C. difficile infection caused by the antibiotics. She spent 3 additional weeks in the hospital and missed 2 months of her beloved bridge games. Here's the practical protocol. If you're over 60 and feeling well, question any routine urine testing. Ask the simple question, what symptoms am I having that make you think I need this test? If the answer is it's just routine or we test everyone, that's your cue to decline. The exception: if you have new burning with urination, pelvic pain, or fever, then urine testing makes sense. But testing urine in healthy older adults without symptoms does more harm than good. But here's the kicker. The urine test problem is just the beginning. Next up is a cancer screening that creates false diagnoses in nearly half of all women over 70-5. Number 4 on our countdown is mammography screening for breast cancer after age 75. And this one's going to challenge everything you've been told about early detection saving lives. Most women believe that mammograms always save lives by catching cancer early. But for women in their 70s and older, the risk of overdiagnosis with routine screening mammography is substantial. Overdiagnosis means finding a real cancer that would never have caused problems during the woman's lifetime. These are slow-growing or non-growing cancers that would never have led to symptoms or death. Here's why this happens more in older women. As we age, we're more likely to develop very slow-growing cancers. It can often take 10 20, even 30 years for a slow-growing breast cancer to cause harm. If you're 75 and have other health conditions, you're statistically more likely to die from heart disease, stroke, or other causes long before a slow-growing breast cancer could hurt you. But here's the shocking data. Among women aged 70 to 74 diagnosed with breast cancer on screening mammography, around 31% would be overdiagnosed. These overdiagnosis estimates rose to 47% for women aged 75 to 84. Think about that. Nearly half of breast cancer diagnoses in women over 75 are cancers that would never have caused problems. Consider Ruth, 79, a former teacher who had survived her husband by 5 years and was living independently. She had mild diabetes and some arthritis, but was still driving and caring for her garden. During her annual mammogram, doctors found a small breast cancer. Ruth underwent a lumpectomy and 6 weeks of radiation therapy. The radiation caused severe fatigue and skin burns that took months to heal. She developed anxiety about her diagnosis and stopped many activities she enjoyed. 2 years later, genetic testing on her tumor showed it was so slow-growing that it likely never would have caused symptoms in her lifetime. Here's the evidence-based approach. After age 75, discuss with your doctor whether continued mammograms make sense based on your overall health and life expectancy. If you have serious heart disease, advanced diabetes complications, or other conditions that significantly limit your life expectancy, mammograms may cause more harm than benefit. Some women choose to continue screening if they're in excellent health with a family history of aggressive breast cancer. But the key is making an informed choice rather than automatically continuing screening. Now let me ask you something. Have you ever questioned a screening test your doctor recommended? If so, how did they respond? I'd love to hear your stories in the comments. Number 3 will really open your eyes. It's the prostate screening that leads to thousands of unnecessary surgeries in men who would have been better off never knowing they had cancer. The PSA blood test for prostate cancer. Screening in men over 75 is causing an epidemic of overtreatment. Here's the uncomfortable truth that most urologists won't tell you. PSA-based screening in men aged 50 to 69 after 9 years results in little or no reduction in prostate cancer-specific mortality. And for men over 75, the evidence for benefit becomes even weaker. Here's how the harm happens. PSA screening finds many prostate cancers that are extremely slow-growing. Most men with prostate cancer will die with it, not from it. If a man is not going to live another 10 or 15 years due to his age, you won't save his life from prostate cancer by screening him, but you will subject him to the potential harms of treatment. The mechanism is straightforward but troubling. When PSA screening finds cancer, the medical system springs into action. Biopsies are performed. When cancer is confirmed, pressure mounts for immediate treatment. Surgery and radiation for prostate cancer can cause permanent incontinence and impotence. Higher rates of myocardial infarction and suicide have been reported in men with prostate cancer in the year after diagnosis. Let me share what happened to Frank, 77, a retired mechanic who loved working in his garage and playing poker with friends twice a week. His doctor ordered a routine PSA test during his annual physical. The level was slightly elevated. This led to a prostate biopsy, which found cancer. Frank was told he needed immediate treatment. He chose surgery. The operation was successful in removing the cancer, but Frank developed severe incontinence and complete impotence. He stopped going to poker games because of embarrassment about his condition. A year later, his cancer pathology report showed it was so slow-growing that active surveillance would have been completely appropriate. Frank lost his quality of life treating a cancer that probably never would have threatened him. Here's the practical guidance. Men over 75 should carefully consider whether PSA screening makes sense. If you have a life expectancy of less than 10 years due to other health conditions, PSA screening is more likely to harm than help. If you're in excellent health with a strong family history of aggressive prostate cancer, you might choose screening, but should understand that active surveillance rather than immediate treatment is often the best approach for slow-growing cancers found in older men. The key question to ask your doctor: if this test finds cancer, what would we do differently at my age and with my health conditions? If the answer involves treatments that could significantly harm your quality of life to address cancers that may never threaten you, that's valuable information for your decision. But we're just getting warmed up. Number 2 on our countdown is the procedure that's supposed to save your life but actually puts tens of thousands of seniors in the hospital every year from complications. This is the screening that might surprise you the most. Colonoscopy for colorectal cancer screening in people over 75 is creating far more problems than it's solving. The data on this will shock you. Here's what they don't tell you about colonoscopy complications in older adults. Each year, between 2.1 and 3.2 million low-value colonoscopies are performed, resulting in an estimated annual incidence of serious harm from unnecessary colonoscopies ranging from 9,000 to nearly 12,000 people. We're talking about preventable serious complications including bleeding, perforation, heart problems, and even death. Why does this happen more as we age? Colonoscopy complications increase dramatically with age. Colonoscopy in very elderly patients carries a greater risk of complications and morbidity than in younger patients, and is associated with lower completion rates and higher likelihood of poor bowel preparation. The bowel prep alone can be dangerous for older adults, causing dehydration and dangerous shifts in blood chemistry. Here's the mechanism that's rarely explained. For patients older than 75 years, overscreening for colorectal cancer is associated with physical and financial costs while often providing little benefit. Even if colonoscopy finds early cancer in a 78-year-old with heart disease and diabetes, the treatment might be more harmful than the cancer itself. Recent research confirms this concern. Among people who had a screening colonoscopy over age 76, 2.3% died or were hospitalized overnight within 30 days, compared with 1.17% of those who did not have a colonoscopy. That means colonoscopy essentially doubled the risk of serious problems in the month following the procedure. Consider what happened to Robert, 81, a retired postal worker with mild heart disease and early kidney problems. His doctor recommended a routine colonoscopy. Robert had no symptoms and no family history of colon cancer. During the procedure, his blood pressure dropped dangerously low. The colonoscopy itself was completed without finding any polyps or cancer. But Robert spent 5 days in the cardiac intensive care unit recovering from the cardiovascular stress of the procedure and developed acute kidney injury that required months of monitoring. He was never the same afterwards, requiring a walker and giving up his daily walks. Here's the evidence-based approach. Current medical guidelines suggest that seniors 76 and older use alternative methods to a colonoscopy, like FIT. The FIT test, or fecal immunochemical test, is a simple stool test you do at home. It's safer and nearly as effective for detecting colon cancer in older adults. If you're over 75, ask about alternatives to colonoscopy. If you do choose colonoscopy, make sure you're healthy enough to handle not just the procedure, but any treatments that might be needed if problems are found. Now I want to hear from you again. What's been your experience with colonoscopy screening? Have you or a loved one had complications or found alternatives that worked better? Share your thoughts in the comments, but the biggest shock is still coming. Number 1 on our countdown is the test that creates more unnecessary procedures and anxiety than any other screening in older adults. The number 1 health checkup to question after age 60 is thyroid cancer screening with ultrasound. This might be the most surprising entry on our list because thyroid problems are so common in older adults. But here's the hidden truth about thyroid cancer screening. Thyroid cancer screening has not been shown to decrease the chance of dying from the disease. Yet ultrasound screening of the thyroid has created an epidemic of thyroid cancer diagnoses. Most of these are small papillary cancers that grow extremely slowly and would never cause symptoms or threaten life. Here's the alarming trend. Over the past 3 decades, thyroid cancer diagnoses have tripled in the United States, but deaths from thyroid cancer have remained essentially unchanged. This is the classic pattern of overdiagnosis. We're finding more disease, but people aren't living longer or dying less from thyroid cancer. The mechanism behind this overdiagnosis is simple but devastating. Modern ultrasound can detect tiny thyroid nodules that previous generations never knew they had. When these nodules are biopsied, many contain microscopic cancers, but these cancers are often so small and slow-growing that they would never have caused problems. The fact that a large percentage of these cancers is unlikely to progress led to suggestions that the terminology be modified to remove the word carcinoma so that the name is more closely aligned with the growing understanding of the underlying biology. Here's what happens in the real world. Ultrasound screening finds a small nodule. Biopsy confirms cancer. Surgery is performed. The thyroid is removed. The patient needs lifelong thyroid hormone replacement. Complications can include voice changes from nerve damage and low calcium levels, requiring daily supplements. All of this for cancers that would likely never have caused symptoms. Take the case of Linda, 73, a retired nurse who was getting an ultrasound of her neck for another reason. The radiologist noted a small thyroid nodule and recommended follow-up. This led to biopsy, which showed a tiny papillary cancer. Linda underwent complete thyroidectomy. During surgery, her vocal cord nerve was damaged, leaving her with a permanently hoarse voice. She developed low calcium levels, requiring multiple daily supplements. 6 months later, the pathologist's final report indicated her cancer was so small and low-grade that active surveillance would have been completely appropriate. Linda's voice never recovered, affecting her ability to communicate with her grandchildren and participate in her church choir. Here's the practical protocol. Avoid routine thyroid ultrasound screening if you have no symptoms. If you develop a new lump in your neck, difficulty swallowing, or voice changes, those symptoms warrant evaluation. But routine ultrasound screening in healthy older adults finds many problems that are better left undiscovered. If a small thyroid cancer is found incidentally, ask about active surveillance rather than immediate surgery. The key principle here is what oncologists call watchful waiting or active surveillance. For many slow-growing cancers found in older adults, careful monitoring be safer than aggressive treatment. Now let's step back and look at the bigger picture. Why is this overscreening epidemic happening to older adults? There are several forces driving this trend. First, doctors fear missing something. Medical training emphasizes the dangers of underdiagnosis, but rarely teaches about the harms of overdiagnosis. Second, patients often request tests believing that more screening equals better healthcare. Third, financial incentives in our healthcare system reward doing more procedures rather than having thoughtful conversations about when less might be more. But here's the most important concept to understand. The balance between benefits and harms of screening changes as we age. Tests that make sense at 50 may not make sense at 75. This isn't about giving up on older adults. It's about focusing on care that truly improves quality of life rather than creating problems where none existed. Think about it this way. If you're 78 years old and screening finds a slow-growing cancer, you're much more likely to die from heart disease, stroke, or other age-related conditions than from that cancer. But the anxiety, procedures, and treatments for the screen-detected cancer can significantly impact your remaining quality years. Here's a simple framework for making these decisions. Ask yourself and your doctor 3 questions. First, what is my overall health status and realistic life expectancy? Second, if this test finds something abnormal, what would the next steps involve? Third, are those next steps likely to improve my quality of life or just create new problems? The goal is to avoid all medical care. It's to be selective about interventions that truly benefit you at your stage of life. Let me share some alternatives that actually do help older adults stay healthy. Instead of focusing on screening for diseases you might never develop, focus on staying strong and preventing falls. Balance exercises can prevent the hip fractures that truly threaten independence in older adults. Social connections protect against depression and cognitive decline more than most medical interventions. Cardiovascular health remains crucial, but this means managing blood pressure, staying physically active within your abilities, and taking proven medications like statins if appropriate. These interventions have clear benefits regardless of age. For cancer prevention, focus on the basics. Don't smoke, limit alcohol, stay as active as possible, eat plenty of fruits and vegetables. These lifestyle factors prevent more cancer than most screening tests. When it comes to routine blood work, some tests remain valuable throughout life. Checking kidney function, blood counts, and diabetes markers can guide treatments that improve how you feel day to day. But exotic tumor markers or genetic tests for diseases you may never develop often create more anxiety than benefit. Here's another key point. If you do have symptoms, that's different. A new lump, unexplained weight loss, persistent pain, or changes in bowel habits warrant evaluation at any age. The issue isn't with diagnostic testing for symptoms. The problem is with screening tests in healthy older adults that are more likely to find problems than solve them. What about family history? This is often used to justify continued screening in older adults. But remember, family history of cancer increases your risk, but it doesn't change the fundamental issue. If you're 78 with serious heart disease, finding and treating a slow-growing cancer may still cause more harm than benefit. Even with the family history, the most important skill for healthy aging in finding more diseases, it's learning to navigate the healthcare system wisely. This means asking good questions, understanding your options, and making decisions based on your values and priorities rather than fear. Let me give you some specific language to use with your healthcare providers. When a test is recommended, try saying, "Help me understand how this test will change what we do." If the doctor can't give you a clear answer about how the results would impact your care, that's valuable information. Another useful question: what happens if we don't do this test? Often, the answer is nothing, or we'd keep watching for symptoms. That might be the safer approach. You can also ask, what are the chances this test will find something that would actually improve my health? Be prepared for the possibility that those chances might be quite small. Remember, you always have the right to decline any test or procedure. You're not being difficult or non-compliant. You're being thoughtful about your healthcare choices. Here's something that might surprise you. Some of the world's healthiest older adults live in cultures where medical screening is less common. They focus on staying active, maintaining social connections, and enjoying their food and family rather than searching for hidden diseases. This doesn't mean ignoring all healthcare. It means being selective about interventions that truly improve your daily life and long-term well-being. One more practical tip: consider bringing a family member or friend to medical appointments. They can help you ask questions and remember the conversation. Sometimes a second person helps advocate for a more conservative approach when the default is to do more tests. Document your preferences. If you've decided against certain types of screening, make sure this is noted in your medical record. This prevents well-meaning providers from repeatedly offering tests you've thoughtfully declined. Here's the overarching principle that should guide these decisions. At every stage of life, but especially after age 60, the goal of healthcare should be to help you live as well as possible for as long as possible. Sometimes this means finding and treating problems early, but sometimes it means avoiding tests and procedures that are more likely to harm than help. The art of medicine is knowing the difference. Unfortunately, our healthcare system often defaults to doing more rather than asking whether more is better. This is why you need to be your own advocate. Learn about the benefits and harms of different interventions. Ask thoughtful questions. Make decisions that align with your values and priorities. Age brings wisdom. Part of that wisdom is understanding that not every medical problem needs to be fixed, and not every test needs to be done. Sometimes the most courageous choice is to say no to interventions that promise cure but deliver complications. As we wrap up, remember that the goal is to avoid all medical care. Effective treatments exist for many conditions that affect older adults. Blood pressure medications prevent strokes. Cholesterol-lowering drugs reduce heart attacks. Vaccines prevent serious infections. Exercise and social engagement protect against depression and dementia. The key is being selective. Focus your healthcare energy on interventions with clear benefits for your situation rather than screening for problems you may never develop. Your doctor should be your partner in these decisions, not someone who automatically orders tests because that's the protocol. If your current provider isn't open to these conversations, consider finding one who practices more thoughtful, individualized medicine. The future of healthcare for older adults isn't about doing more screening. It's about personalizing care based on what matters most to you. This requires honest conversations about your health status, values, and goals. Some older adults prioritize longevity above all else and accept the risks of aggressive screening and treatment. Others prioritize quality of life and comfort, choosing less intensive medical interventions. Both approaches are valid. The important thing is making informed choices rather than defaulting to standard protocols that may not serve you well. Here's my final challenge for you. Take charge of your healthcare decisions. Don't be a passive recipient of whatever tests and procedures the system offers. Be an active participant who asks questions, considers alternatives, and chooses interventions that truly benefit you at your stage of life. The most dangerous phrase in medicine might be everyone your age gets this test. You're not everyone. You're a unique individual with your own health status, values, and priorities. Your healthcare should reflect that individuality. Sometimes less truly is more. Sometimes the bravest choice is to focus on living well rather than searching for problems. Sometimes the wisest approach is to age gracefully rather than fighting every possible threat to your health. The choice is yours. But now you have the information to make that choice, thoughtfully rather than automatically following recommendations that may not serve your best interests. Which of these 5 screenings resonates most with your experience? And what changes will you consider making in your own healthcare approach? I'd love to hear your thoughts and any stories you're comfortable sharing about navigating these decisions.